It is often assumed that wartime medicine, even under extreme conditions, followed clear rules and predictable categories. Soldiers were treated as soldiers, civilians as civilians, and prisoners of war as a uniform group governed by international convention. The historical record shows something far less orderly. In practice, military medical systems were improvised, overstretched, and shaped as much by ideology and logistics as by professional standards. Nowhere was this more evident than in prisoner of war camps, where the presence of women, especially women captured outside traditional combat roles, posed administrative and medical problems that authorities were neither prepared for nor fully willing to resolve. By the middle years of the Second World War, most major powers operated extensive networks of POW camps. These were designed with a specific prisoner in mind: a male enlisted soldier, captured on the battlefield, classified by rank and nationality, and expected to survive captivity long enough to be repatriated at war's end. Medical planning reflected this assumption. Camp infirmaries were staffed to treat malnutrition, infectious disease, work-related injuries, and psychological exhaustion among adult men. When women entered these systems, they did so as exceptions, often without clear legal or medical categorization. Records from German-administered camps in occupied Europe indicate that female prisoners appeared under several classifications. Some were captured as resistance members, others as auxiliary military personnel, nurses, or administrative workers attached to armed forces. Still others were civilians detained during sweeps, reprisals, or labor roundups and later reclassified as prisoners. Their numbers were always small compared to male captives, but their presence created persistent uncertainty within camp administrations. According to camp reports, female prisoners were frequently transferred between facilities, reassigned from POW camps to labor camps, or held in segregated sections improvised within male-dominated compounds. Within this context, one medical file from a camp infirmary in Central Europe offers a revealing example. The woman identified in the file is not named in surviving documents. She is described only by age, early 30s, nationality, and status as a prisoner under military custody. Her arrival at the camp is recorded without detail. No account survives of her capture, her political activity, or her prior occupation. What remains is the clinical problem she presented and the difficulty the medical staff encountered in managing it. According to contemporary accounts, she was admitted to the infirmary after several weeks in the general prisoner compound. The initial notes describe persistent weakness, episodes of fainting, and abdominal pain. These symptoms were not unusual in POW populations, where inadequate nutrition, dehydration, and infectious disease were common. Yet her case diverged from the norm almost immediately. Camp doctors noted irregular bleeding, rapid weight loss, and signs of hormonal disturbance. The language of the file is cautious and technical, avoiding speculation while repeatedly noting uncertainty. This uncertainty was not merely diagnostic. It reflected a deeper structural problem within the camp's medical system. Female reproductive health was not an area of training for most military doctors, particularly those operating in field or camp conditions. Gynecological instruments were scarce or non-existent. Diagnostic imaging was unavailable. Laboratory testing was limited to basic blood counts, when reagents could be obtained at all. In such an environment, even routine conditions became difficult to assess. According to camp medical regulations, prisoners deemed unfit for labor were to be treated and returned to work as quickly as possible. Long-term care was discouraged. Transfer to civilian hospitals required authorization from multiple administrative levels and was rarely granted for prisoners. In the case of this woman, her symptoms did not fit neatly into categories that justified exemption or transfer. She was not visibly contagious, nor was she acutely injured. Yet she was repeatedly unable to meet labor quotas, collapsing during roll calls or work details, Witnesses later recalled that the infirmary staff debated her status repeatedly. Some doctors suspected advanced malnutrition combined with stress-related endocrine disruption. Others considered gynecological pathology, but acknowledged they lacked the means to confirm it. There's no indication in the records that sexual violence was alleged or investigated. A silence that reflects both the limitations of documentation and the broader reluctance of military institutions to acknowledge such possibilities. What is clear is that her body became, in administrative terms, a problem. According to camp reports, she occupied a bed for weeks at a time, was discharged back to labor details, then readmitted after further collapse. Each admission required paperwork, ration adjustments, and justification to superiors who were increasingly focused on productivity rather than care. The medical file includes marginal notes, questioning whether her condition was functional or constitutional, terms often used at the time to suggest psychological or inherent weakness rather than organic disease. Such language was common in wartime medical discourse. Under conditions of scarcity, physicians were encouraged implicitly and sometimes explicitly to distinguish between prisoners who could be restored to labor and those who could not. Those deemed chronically ill posed a logistical burden. For male prisoners, this often resulted in transfers to so-called recovery camps or, in the worst cases, neglect. For women, whose labor roles were already viewed as secondary, the situation was even more ambiguous. According to contemporary accounts, the woman was eventually reassigned to lighter duties, including indoor work, though this did not resolve her condition. The medical notes become increasingly sparse over time, suggesting either normalization of her symptoms or resignation on the part of the staff. At no point does the file indicate a definitive diagnosis. The final entry records her removal from the infirmary roster following a camp reorganization. Whether this meant transfer, release, or death is not stated. This absence of resolution is itself historically significant. POW medical records were designed to track treatment outcomes, yet many files end abruptly. This reflects the chaotic nature of late war administration, as camps were evacuated, destroyed, or reorganized under pressure from advancing armies. It also reflects the limited value assigned to prisoners' long-term health, particularly when that health did not align with immediate labor needs. The case illuminates broader issues within wartime medical systems. Military medicine is often portrayed as a field of innovation, driven by necessity and scientific advancement. While this is true in some contexts, POW camps represented a parallel system where innovation was constrained by ideology and resource allocation. Prisoners were not beneficiaries of medical progress. They were subjects of minimal maintenance. For women in these systems, the challenges were compounded. Their bodies did not conform to the assumptions underlying camp design. Sanitation facilities were inadequate. Menstrual hygiene was poorly addressed, if at all. Nutritional requirements specific to women were not recognized. According to camp regulations, rations were standardized by labor category, not biological need. This standardization ignored differences that could exacerbate health problems over time. Medical officers operating in camps were often aware of these deficiencies. Some attempted to compensate through informal measures, adjusting work assignments, or providing additional rest when possible. Others adhered strictly to regulations, viewing deviation as both futile and professionally risky. In either case, their actions were constrained by a system that prioritized order and output over care. The woman's case also highlights the limits of international law during the conflict. The Geneva Convention provided guidelines for the treatment of POWs, including access to medical care. However, enforcement mechanisms were weak and interpretations varied widely. Female prisoners occupied a particularly uncertain position within these frameworks. As the conventions had been drafted with male combatants in mind, according to Red Cross inspection reports from the period, visits to camps housing female prisoners often focused on accommodation and labor conditions rather than medical care. Inspectors noted overcrowding, poor sanitation, and inadequate clothing, but detailed medical evaluations were rare. Chronic conditions, especially those not immediately life-threatening, received little attention in official reports. In the post-war period, historians and legal investigators struggled to reconstruct individual experiences from fragmentary records. Medical files like the one described here were often incomplete, damaged, or deliberately destroyed. Where they survived, they provided glimpses into daily operations rather than full narratives. The woman remains an example rather than a subject with a recoverable biography. Her case does not suggest deliberate medical experimentation or overt cruelty by the doctors involved. Rather, it reveals a system in which indifference, limitation, and bureaucratic inertia produced suffering without requiring malicious intent. The doctors struggled not because they lacked skill, but because the system in which they worked defined the boundaries of their responsibility narrowly. From a historical perspective, this distinction matters. It shifts attention away from individual morality and toward institutional design. Wartime medical failures were often the result of structural choices. Who deserved care? How much care was enough? And when a body ceased to be worth preserving, the presence of women in POW camps exposed these choices with particular clarity. Their medical needs could not be easily absorbed into existing frameworks. Their illnesses disrupted assumptions about labor, discipline, and efficiency. In this sense, they revealed the fragility of systems built on rigid categories. The war produced millions of prisoners, and most survived without leaving detailed records. Yet cases like this one remind us that survival itself does not equate to adequate care. Between life and death lay long periods of unmanaged illness, uncertainty, and neglect. These experiences rarely appear in official histories focused on battles and diplomacy. As historians, we rely on what remains, a medical file with unanswered questions, reports that note problems without resolving them, and the knowledge that many similar cases went undocumented. The woman in this camp was not unique. She represents a category of prisoners whose existence challenged the administrative logic of wartime captivity. In examining her case, we gain insight not only into the conditions of POW camps, but into the limits of wartime medicine itself. The struggle of doctors to handle her condition was not a failure of diagnosis alone. It was a reflection of a system that had not imagined her presence and therefore could not adequately respond to it. This is what her medical file ultimately reveals about the war. That even in institutions designed to manage human bodies with precision, there were lives that fell outside the margins of planning. Their experiences, preserved only in fragments, remind us that war's impact was measured not only in casualties and victories, but in prolonged, unresolved suffering that resisted categorization and, for a long time, historical attention.